Good afternoon to everyone. I'm Scott Cassie, one of the general surgeons, bariatric surgeons here at Thunder Bay Regional. Welcome this afternoon. We wanted to put together a nice comprehensive discussion of what's available for obesity management these days, because it's just so vast and pretty overwhelming in some cases. And so we're very fortunate today. Dr. Taib Khan is going to be joining us. He is at Western University in London. Dr. Khan is an endocrinologist. He's a bariatric medicine specialist and a diplomat of the American Board of Obesity Medicine. He's been heavily involved in starting the bariatric medicine program in London and oversees the fellowship program there. So this is a wonderful opportunity today to give a nice comprehensive overview. He has started working with us here in our clinic as well, and seeing some patients and assisting with pharmacotherapy here. So Dr. Khan, welcome. We thank you very much for joining us today. We'll share this talk. Dr. Khan has agreed to present on some of the non-pharmacologic therapies, some pharmacotherapy. I'll talk about surgery, and then Dr. Khan's been very gracious. I think he really is the authority on management of obesity these days. And so he's going to take us through a case at the end and really highlight his decision-making, his algorithm that he follows to determine what's best management for these patients and how can we combine therapies if necessary. So Dr. Khan, thank you for joining us today. And we have a lot to get through the next hour, so we're going to start right now and see if we can leave about 5 or 10 minutes at the end for some questions. I'm having some troubles with my computer. It will not broadcast any of the slides, so Kelly's going to do this for me. I apologize. It might be a little bit glitchy, as I'm going to be asking her to advance slides as we go through this.
Sorry, I'm just having some trouble advancing the slides, so just give me 1 second. I'm going to try again.
Okay. So if you can just go back to the outline for 1 second there, Kelly. Sorry, I couldn't see it myself for a second. I think everything's working now. Yes, objectives today, as I mentioned, we'll just very quickly go over obesity trends and impact on health. Everyone knows the numbers nowadays. We'll touch on the pillars of obesity management, but the bulk of this will be about the treatment options available, the non-pharmacotherapy, the pharmacotherapy, and the surgery. And as I mentioned, we'll take us through a little algorithm with Dr. Khan, how to decide what to initiate and how we're going to advance treatment. Next slide. So we know the rates today. About a third of Canadian adults, about 40% of US adults are considered obese. Here in Ontario, we're sort of on par with the Canadian average. And in Northwestern Ontario, the last Senate report, about 31% rate of obesity. That's now about 9 years old, so those numbers may have changed since then. There's also been a survey done more recently closer to Thunder Bay, and in that region, it was actually thought that the obesity rate may be as high as 38%, which is astounding. Overall, about 2/3 of Canadian adults and about a third of Canadian children are considered either overweight or obese. Next slide. We all know the implications of this. The excess fat accumulation really has some pro-inflammatory effects, some estrogenic effects. The take home from this is we know about diabetes, high cholesterol, and cardiovascular disease, but really when you sit down and look at it, obesity affects every single major system with some detrimental impact. And so it's important to consider this moving forward. It's not even just the regular healthy systems that are affected. Cancer is another big one. So next slide, please. We have many cancers are now linked with obesity. The main ones would be things like breast, colon, ovarian, endometrial, as well as things like pancreatic, esophageal, and a handful of others as well. And so we have to consider the implications of this moving forward. Next slide. So at a system level, when we consider this, somewhere between 50 and 60,000 Canadian deaths per year have been estimated to be due to conditions associated with obesity. If you look back in 2016, it was felt the annual cost of obesity to the system was somewhere between $5 and $7 billion, and you factored in both the healthcare and reduced productivity costs. There's been a more recent study just released suggesting that cost may be as high as $27 billion per year, about $6 billion in direct healthcare costs, and about another $20 billion that's due to both reduced workforce participation, presenteeism, absenteeism, as well as things like premature mortality and disability pensions. So the implications of this are huge. Next slide. Next slide. Perfect. is a huge implication for the system. But we look at our patients specifically, which is probably the most concerning thing. There's been some estimates that being obese may decrease lifespan by anywhere from 6 to 14 years. There's been some estimates that for every 5-point increase in our body mass index may be associated with at least a 16% increased risk of sudden cardiac death. And we have some older papers that say if you're severely obese at middle age, you've probably increased your risk of early death by at least 50%. So when we look at this, knowing the implications of obesity, knowing some of the trends and the worsening numbers worldwide over the last number of years, there really is some urgency to defining what's the best management, how do we combine therapy to give obese patients the best possible outcomes long term. Next slide. And the pillars of obesity medicine, really there's 3 or 4, depending on which resource you use, but they've essentially identified that obesity is a chronic disease and it needs to be managed as such. So there probably is no one therapy that's going to give patients the best possible outcomes. This really comes down to selecting treatments from each of the pillars, and in most cases, patients probably benefit from at least 1 or more treatments from each of the pillars. And so if we're going to treat a chronic disease and give patients good chronic long-term outcomes, we need to treat it as such. And so we really need to focus on all the different aspects of care to make sure patients get the best possible outcomes. Next slide. So as I mentioned, Dr. Khan will go through non-pharmacotherapy and pharmacotherapy. I'll try to race through surgical options after that, and then we'll have a discussion developing a case and possibly some combination therapy. So Dr. Khan, I'll turn things over to you now.
Thanks so very much, Dr. Cassie and Kelly, and it certainly is a pleasure to be back and present to you on obesity. So, as Dr. Cassie mentioned, the pillars include non-pharmacologic therapy, and we've all heard of dietary approaches to treat obesity. So, low carbohydrate diet or ketogenic diet has been used for quite a few years. So this was one of the earlier studies that showed that it was efficacious. So low carbohydrate diet, where people only took about 50 grams of carbohydrates in a day, compared to low fat, low calorie diet. So in this, patients basically took about 1,700 calories per day as well. So at the end of the 1-year period, both groups lost some weight. It was in the order of between 5 to 6% of weight loss, and there was no differences between the 2 groups, suggesting that while low-calorie diet can be effective, combined with low fat, so can be low-carbohydrate diet. But once again, that 5 to 6% weight loss is important to remember, because that's what's been seen in randomized control trials. Next slide, please. Intermittent fasting. So this was basically a Chinese study, that randomized people to time-restricted eating or intermittent fasting. So these people had all their calories between 8 a.m. to 4 p.m. So that sort of 8-hour time window, versus daily caloric restriction, when they only had between 1,500 to 2,000 calories per day. There were similar reductions in weight loss, by the end of a year. So this was just upwards of 6% weight loss in this randomized controlled trial. In terms of improvements in LDL, triglycerides, blood pressure, there was the improvements were similar, suggesting that these strategies could be important in leading to clinically useful weight loss. Next slide, please. So, which takes us to the medical bariatric program, which has been functional in Thunder Bay for a number of years now. So we have a total of 100 patients per year that go through the medical bariatric program. And the premise of that is based on a holistic program that combines meal replacements along with appointments with social worker, dietitians, on a weekly basis to sort of reinforce concepts regarding maintaining a healthy diet even after meal replacement period is done. So the initial first 6 months comprise treatment phase with meal replacements. So for the first 13 weeks, patients are only taking meal replacements, and then there's a gradual reintroduction of regular foods, and then followed by a maintenance phase of 6 months thereafter. Next slide, please. So the evidence for this came through the OptiWin study. So this was published about 5 years ago now, where basically, they compared people taking meal replacement. So at that time, we had OptiFast available versus just 500 to 750 calorie restriction every day for participants. Everyone was encouraged to participate in 150 to 180 minutes of physical activity, and everyone received behavioral counseling. Next slide, please. With this comprehensive program, by the end of the first 6 months, participants in the meal replacement program lost about 12% of their starting weight. The other intervention that comprised caloric restriction was also effective, but as was seen in previous studies as well, they lost about 6% of their starting weight, which there was a little bit of weight regain after, at the 1 year mark. But still, patients did lose about 10% of their starting weight in the meal replacement program. So that is the basis, the scientific basis for us using meal replacement programs today. Next slide, please. So, which takes us to anti-obesity medications, which is another pillar of weight management. So there are several that have been available. So naltrexone bupropion basically works on curbing the cravings. So works on the dopamine, norepinephrine system, and help with hedonic eating, if you will. It's an oral formulation. Liraglutide and semaglutide have been approved both for weight loss. They do have a central effect in appetite suppression, but also work on the gut as well to decrease gastric motility, and food stays in stomach for longer, and one has the feeling of satiety after taking them. Orlistat has been around for the longest time. It's basically a lipase inhibitor, and leads to basically lack of fat absorption. Side effects are steatorrhea with it, so it's another oral medicine, but because of its side effects and efficacy, which I'll allude to, is not used as first-line agents. Next slide, please, Kelly. In terms of orlistat, it's been around for the longest time. So this is a meta-analysis that combined all studies available then with orlistat. So in total, the percentage weight loss with orlistat is in the order of just about 3%. When we look at the meta-analysis, and because of this, so it is effective, certainly. However, given that we have agents that are more effective than it, side effects do include significant steatorrhea at the 120 milligram 3 times daily dose. Because of that, it's not our preferred agent or first-line agent for treating patients with obesity. Next slide, please. Naltrexone bupropion has been around for about just over 5 years now. Individually, this medicine has been around for several decades. So naltrexone can be used, for opioid intoxication, for patients who've had a history of alcohol misuse as well. And bupropion has been an antidepressant, but the combination helps reduce cravings in patients. So this study was done in those without diabetes, and over a course of just over a year, this led to about 8% weight loss compared to placebo, where just about 2% weight loss was seen. All of these patients did receive counseling, excuse me, regarding healthy eating, regarding caloric restriction, as well as physical activity in this randomized control trial. So suggesting that there can be a plateauing of the effect, around 32 weeks time point. However, the weight loss from then on is basically sustained, and can be effective agent for weight loss in these patients. Next slide, please. In terms of liraglutide, so as you know, there's 2 doses available. So the typical one that we use for diabetes is 1.8 milligrams. So these were the scale trial results, which looked at the 3 milligram subcutaneous once daily dose of liraglutide. And once again, these patients, the study was done in those without diabetes. So, with a certain percentage did have pre-diabetes though. but the results were similar, in those with pre-diabetes and without diabetes, that, over a course of a year, it did lead to about just about 8% weight loss compared to placebo, where those participants had just about 3% weight loss. So once again, all of these participants did receive counseling regarding lifestyle approaches, regarding healthy eating, caloric restriction. So liraglutide was found to be more efficacious compared to placebo. Next slide. In terms of semaglutide, so once again, subcutaneous. So there's an oral formulation as well, but the data that I'm showing pertains to the subcutaneous formulation only. So the oral formulation is modestly effective, leads to about 4% weight loss at the doses we have available yet. So this is data for the 2.4 milligram dose of semaglutide subcutaneously once a week. So two things that I'd like to draw your attention to. So first was that the plateauing of the effect happens slightly later, around the 1 year time point, compared to that seen with liraglutide, and prior to that with naltrexone bupropion, where it can happen anywhere between 30 weeks or so. It did lead to about 14% weight loss, which was greater compared to just about 2% seen in placebo. So you do see a trend emerging that with lifestyle interventions, we do see between 3 to 5% weight loss, which can still be clinically useful in some conditions. And these medications that we have available, as well as the other interventions like meal replacements, they do lead to further weight loss compared to that seen with lifestyle interventions. Next slide, please. Now, tirzepatide has, I would like to clarify, it has not yet been approved for weight management here in Canada. It has been approved in the States. It has now been available and is being used for diabetes, but is off-label, strictly speaking, for weight management. This is one of the earlier trials, and in this we did see about close to a 20% weight reduction with tirzepatide 15 milligram dose. Subsequently, a study has been done in those with diabetes. Even in those with diabetes, we do see about a 15% weight loss, which was greater compared to that seen with 1 milligram of semaglutide dose. So suggesting that it is more efficacious. It is once a week. It is a GLP-GIP receptor agonist. And is very effective for treatment of diabetes as well, and could be an effective treatment modality for these patients struggling with obesity or diabetes. Once again, in the placebo group, we do see about a 3% weight loss, which is consistent with what we've seen in other randomized controlled trials. Next slide, please. So just to summarize, so far the pharmacotherapy that has been approved for weight management are the following. So orlistat, as I alluded to, leads to about 2.9% weight loss. Liraglutide, 5.4% compared to placebo. Overall weight loss can be about 8%. Same goes for naltrexone bupropion, just under 5% compared to placebo. Overall, close to 8% as well. And semaglutide, 2.4 milligram subcutaneous, 12.5% greater weight loss compared to placebo. Overall, about 14 to 15% depending on studies. So those are the ones that are available for weight management. So it is important to keep that framework in mind, like that patient that comes to your office and wants to lose, say, 25-30% of their weight. I mean, letting them know that a small percentage of patients, on medications can lose that amount of weight. However, the average person does not. And, if that is the goal, we should consider other interventions like potentially bariatric surgery for those patients if they are agreeable. So it is very important to keep sort of realistic expectations. Too often patients come in with the expectation that they lose, 30-35% of their weight with these medications. I mean, they are very effective, but we're not there yet. Next slide, please. So just briefly about combination treatment. So we have seen people that respond, that have an initial response, the weight then plateaus, and then it starts to go up, or there can be a small minority of patients that do not respond at all. So what do we do in those situations, strictly in terms of pharmacotherapy? So this study was a retrospective analysis. So these participants had been on GLP-1 receptor agonists like semaglutide or liraglutide. They had added naltrexone bupropion on top of GLP-1 receptor agonists. So the effect is not synergistic, meaning that the added effect of naltrexone bupropion is not greater than the 5 to 8% weight loss that we've seen in studies. So, however, it is effective that on top of the weight that they lose through GLP-1 receptor agonists, they do tend to lose about 4% weight loss that is sustained over 12 months, suggesting that there could be a role of combination therapy. When they had done this, the patients that experienced nausea and vomiting was slightly higher. So in the GLP-1 groups, it was about 10% had experienced nausea and vomiting. When they added naltrexone bupropion or Contrave, it was about 13 to 14%. So that is an issue, and perhaps a slower titration may be used, but there can be a role of combining therapy, particularly with two drugs which are in a different class compared to each other. Next slide, please. In terms of meal replacements and anti-obesity medications, so these are data from the STEP 3 trial, in which these participants had been on meal replacement therapy and plus 2.4 milligrams of semaglutide. So this is the blue graph here, compared to when they were only treated with semaglutide. So when you look at what happens at 68 weeks, so which is 1 year and about 3 months, we do see that the curves are pretty close together. So the total weight loss was similar. However, those that were taking meal replacements in addition to semaglutide did have faster weight loss in the initial period, which was seen in this study. And if patients were on meal replacement alone, they did lose about 5% weight, which was sustained over a year, compared to placebo, where only 2% weight was lost, suggesting that there could be a role of combining meal replacements with anti-obesity medications. The overall outcome is similar. However, the weight loss is faster in patients that combine these two approaches. So that is something that is on offer in Thunder Bay as well, and other medical bariatric programs as well, for that select patients that have coverage and are agreeable to starting pharmacotherapy in addition to meal replacements. Next slide, please. What happens after bariatric surgery? So, we've had patients who do gain weight after bariatric surgery. It is the most effective intervention, for long-term success in weight loss. But in this study, this was a randomized control trial where patients had a Roux-en-Y gastric bypass, which is one of the studies, one of the modalities for weight loss that is available in Thunder Bay as well. They had lost 25% of their starting weight, so it was highly effective. But in this study, they selected participants who had gained 10% of their original weight back. So they'd lost 25%, but gained 10% of their original weight back. So they were randomized to 3 milligrams of liraglutide versus placebo. It was a very small study, but it was a randomized trial. And there was no weight loss in the placebo group. In fact, a little bit of weight gain. However, those that were treated with 3 milligrams of liraglutide did lose about just over 8% of their starting weight over 12 months, suggesting that there could be roles for anti-obesity medications after bariatric surgery as well. Next slide, please. Finally, data regarding semaglutide after bariatric surgery. So unlike the previous study, which was a randomized control trial. This was a retrospective analysis where they looked at patients who had had bariatric surgery and then weight regain and were treated with either liraglutide, so 3 milligram dose, versus semaglutide. So at the end of 1 year, the patients on 1 milligram weekly dose of sema did lose more weight compared to liraglutide. With liraglutide, it was similar in the order of about 8%, but there was an additional 4% weight loss seen with semaglutide in this retrospective study, showing that sema and liraglutide, both subcutaneous injections, could be effective in leading to weight loss after bariatric surgery as well. Okay. Moving on to Dr. Cassie's talk about surgical management.
Thanks a lot, Dr. Khan. He's a wealth of knowledge. I've heard the same talk a few times. I think every time I hear it, I learn a few new things I didn't catch before. So thank you very much for putting that together. That's fantastic. We'll move on to surgery now. We'll try and get this done the next 20 minutes or so we have lots of time to do the case and some questions. So we'll rip through this. A lot of it's well known by now, but in terms of who we look at for surgery, is basically follow the NIH guidelines. If your body mass index is over 40, or if it's over 35 with some sort of obesity-related comorbidity, you're considered a candidate. Now, as we'll talk about in a few minutes, we've seen some pretty vast improvements in metabolic disease after surgery. And so based on that, the American Society changed their recommendations a few years ago, such that now it's recommended for body mass index over 35 or a BMI over 30 with severe metabolic disease. And this sort of reflects what we're seeing worldwide right now, the introduction of what's been known as metabolic surgery. So the lower BMI patients who have severe metabolic disease, who seem to have a good response to surgery with regards to disease improvement or resolution. Next slide. So currently what's out there, it really involves about 3 procedures or 4, sleeve gastrectomy, roux-en-y gastric bypass, and then duodenal switch and what's called SADE, which are essentially the same operation with a slight anatomic variation. So I'll go through these fairly quickly just so everyone knows what's involved with those. Next slide. With the roux-en-y, it's really considered both a restrictive and malabsorptive procedure. We section the stomach off into a small pouch, about 30 cc's, and we bypass the duodenum by about 100 centimeters, 150 centimeters. So there's this malabsorptive component to it as well. The weight loss occurs, we think, through a variety of mechanisms. The prevailing theory is a lot of this is probably due to changes in gut hormone signaling. We see pretty consistent changes in GLP-1 and 2, peptide Y, things like that. And so that's the prevailing theory as to why most of these patients lose weight. We'll touch on more numbers later on, but by and large, if you look 1 to 2 years post-op, the weight loss is pretty good. It's somewhere between 20 and 35% total body weight loss. And it's worth noting that is a little bit better than we see with the sleeve. And the comorbidity resolution is also a bit better, which we'll touch on later on. The one thing people tend to forget is it's also fantastic for GERD. So if you refer an obese patient today to one of our thoracic surgeons for, say, an anti-reflux procedure, most of those are referred basically directly to us. They tend not to operate on those who have BMI over 35 for this condition. And we see very good resolution of reflux after that procedure. Next slide. Kelly, if you can just start that video there. So it's a little schematic of what a bypass looks like when we're performing that. This is technically challenging in really high BMI patients. So once the BMI is over about 55 or 60, we tend to shy away from it. Patients who've also had extensive surgery, lots of adhesions, or if you have large ventral hernias containing bowel, those are all very cases where you probably don't want to offer a bypass. The other thing to keep in mind is once it's done, there's very few and very difficult revisional procedures you can do for things like failed weight loss or weight regain. So these are occasionally converted to a duodenal switch, but it is a pretty major undertaking. In terms of complications, we have sort of the usual perioperative stuff, risk of DVT and PE, which is about 1%, risk of leaks, which we think is 1% nowadays. But the more chronic things you worry about are things like marginal ulcers. That risk is usually around 5%. And so patients can never smoke and can never take anti-inflammatories after this. We do see what's called internal hernias, which is a twisting of the bowel after surgery. That's a lifelong risk and usually occurs in about 1 to 4% based on the most recent data. Dumping syndrome is still seen, but really I'd say a thing of the past. The patients are usually very well educated by the time they come for surgery, and biliary disease is huge in anyone who loses weight rapidly. So we can see stone formation as much as 30 or 40% in that first year. Next slide. Sleeve is considered the number 2 procedure here in Ontario. So Roux-en-Y makes up about 80 to 90% of procedures. Sleeve makes up about 10 to 20% here in Ontario. But if you look worldwide, this is the most prevalent procedure being done currently. We essentially put a little sizer down the stomach and you remove most of the body in fundus. So you're taking out somewhere between 80-85% of the stomach. So it is considered a restrictive procedure. But that being said, we do see some hormonal changes that go along with it, changes in ghrelin, leptin, things like that. So there are hormonal aspect of it as well. The total body weight loss, again, a little bit less when we see with bypass. We think at 1 to 2 years, it's probably around 20 to 25%, somewhere in there. The nice thing about the sleeve is technically it's a little bit less challenging. And so if you have patients who have a very high BMI, if you have patients who have lots of previous surgery, extensive adhesions, large hernias, we can usually work around those. And so in those types of patients, it's sort of our go-to procedure. The other consideration is it's non-ulcerogenic. And so for patients who require long-term NSAIDs, they can still take those down the road after that first month or so after surgery. So it is a good option in patients with chronic arthritis. And the new aspect of things is smokers. So typically in the past, smokers have been denied surgery until they are smoke-free for a certain amount of time. The thought process is that they are doing something they can to improve their health. And so cutting those patients out completely when they recognize that their weight may be a challenge to their health probably isn't the right thing to do. And so more procedures are being done both here in Ontario and elsewhere. In smokers, we usually recommend they come off cigarettes before and after surgery, at least in the immediate perioperative phase. But they can, if they think they're high risk or if they're planning to smoke down the road, they can have a sleeve gastrectomy. We don't think there's any increased risk of ulcers beyond the average population. Next slide. You can start that schematic as well, please, Kelly. So because the decreased malabsorption with the sleeve, it is nice in some other diseases, things like inflammatory bowel disease. This would be the go-to. Patients with severe cirrhosis, I should say mild cirrhosis, may undergo this procedure. And instances where there's chronic steroids or immunosuppression, this may also be an effective procedure for them. The sleeve is also nice because if necessary, it can be converted to a gastric bypass or to a switch or SAIDI down the road if necessary. And the complications perioperatively is about the same as a bypass. Postoperatively farther out, we are concerned about reflux. So it probably induces reflux in at least 30% of patients. And in some of those, it can be quite severe. And because of that reflux that's induced, we do wonder if we're also inducing Barrett's esophagus in some patients, and there's some early data to suggest that. We also think that the risk of weight regain may be a little bit higher with this compared with bypass. Next slide. The last one then is duodenal switch or SAIDI. It is essentially the same procedure. So it involves a sleeve gastrectomy, so trimming that stomach down and then bypassing a very long segment of small bowel. There's what's called a loop formation or distal anastomosis. And so that's the primary difference, but you're essentially achieving the same thing overall. Next slide. And Kelly, if you can just start that video about 20 seconds in, this one's a bit long. So as I said, it's a combined restrictive malabsorptive procedure, but the caveat is it has a much higher degree of malabsorption than the Roux-en-Y. And so because of the significant malabsorption, we actually see more significant weight loss with this and a little bit better comorbidity resolution, especially in terms of things like diabetes. It's a pretty highly specialized procedure. So it was offered only at one center in the province. Now it's being offered at 3, so it is growing somewhat. Right now it makes up about 5% of the procedures that are being done here in the province. And basically, because it's more labor intensive and a little bit higher risk for malnutrition, these patients are required to undergo lifelong follow-up at a care center of excellence. This is a much higher acuity procedure, and so we need to stay on top of things a little bit more so than with the other procedures. And so you'll see here in the schematic, they've already done the sleeve. They're going to bypass a very long segmented bowel, and they'll pull this end up to the duodenum. And there's a nice schematic of some flow through here, but I think we can probably skip through that. So we'll just go to the next slide now, please, Kelly. And then that moves on to SAIDI. As I said, with SATI basically achieves the same thing. If you can just show that video as well, about 20 seconds in. Essentially achieves the same thing. And so because of the issues I talked about, we tend to reserve these for the very high BMI patients, probably at least 55 or 60 in most cases, or a body mass index over 40 with very severe comorbidities. It is used on occasion for weight regain. So patients who've had sleeve or some patients who've had bypass, those can both be converted to SATI or switch if necessary for those weight regain patients. The complications are a bit more frequent. Protein malnutrition occurs probably in at least 5%. Micronutrient deficiency is a big one. These patients have a bit more of a regimented schedule than the bypass patients. We do see deficiencies of things like vitamin D as much as 89% in some studies. Most of the other micronutrients are a bit lower. They're more in the 50 to 60% range, but it is a known issue. Diarrhea can be a problem. Patients usually have about 2 to 3 soft stools per day. Some will have a bit more, and so they are at risk of dehydration. And because you've done a sleeve gastrectomy, they are at risk of reflux as well, bile in some cases, and acid in others, depending on which procedure they've undergone. And again, internal hernias can occur, same as with a bypass, and the risk of that is about the same. So there's a lot of good procedures out there, a lot of options to choose from, but is it worth doing this? And we'll go to the next couple slides, please, Kelly. So first of all, is it safe? Well, we think so. With the introduction of laparoscopy, we saw some vast improvements in outcomes. And on top of that, if you look at our stapling techniques and devices that we have available, as well as the energy sealing devices we use to get hemostasis, there's been some huge improvements over the last 15 years. And so with those things alone, the numbers in terms of complications have decreased significantly. Next slide. So the earliest study that really looked at this, that we look at, is the LABS study. That essentially just looks at risk of mortality in the first 30 days after surgery and the complication rates. And the rates were about 4% for complications. But most importantly, the death rate was about 0.3%. So this is a pretty low number compared to what most people will associate when they think about bariatric surgery. Next slide. If you look at more recent data, these studies have been essentially replicated here at the OBN. And what we've seen is risk of leaks is very low. It's less than 1% based on data from 2016. Risk of reoperation is around 4%. And the mortality of surgery based on this study was about 0.16%. More recently, if you look at the OBN numbers, the latest mortality we've seen is about 1 per 1,000 or less. So that sounds very low. If you can just skip ahead a couple slides there, Kelly. Just the mortality. Perfect, thank you. It sounds very low, but what does it actually mean? There's a group from Finland that wanted to assess this, and so they compare bariatric surgery to a lot of what we sort of consider run-of-the-mill, everyday elective procedures that we do. Interestingly, when they looked at the 30-day mortality, they found that mortality of bariatric surgery is actually similar to what we see with gallbladder removal, hysterectomy, and total knee arthroplasty. The other procedures that are also pretty commonplace here at the hospital, things like colon surgery, hip replacement, and CABG, those actually had substantially increased risk of mortality at 30 days. Next slide. And we looked at the one-year data. Interestingly, they found that survival after bariatric surgery was significantly better than all other procedures, including cholecystectomy, believe it or not. So hard to know whether these truly compare like that, but I think it's worth noting because there's still this connotation that patients who go for surgery are undergoing a massive risk. There certainly is risk. We know that, and that's why our patients are seen by such a large team to make sure they're good candidates. But if you look at the numbers here, it suggests that the mortality rates, the complication rates are probably in line with stuff that we consider as sort of regular everyday procedures here at the hospital. Next slide, please. So I skipped ahead to weight loss. I don't think it's the most important thing necessarily. We're doing this to improve health, but it is one of the first questions we're asked. Don't patients regain weight? Don't they regain all their weight? What's the long-term outcome? We've got some pretty decent numbers. There's no question there is weight regain in some patients, but if we look at some of the bigger studies, looking at sleeve, 1,000 patients and following these patients for 10 years, in this study, patients were able to maintain a total body weight loss of about 24%. Next slide. And if you look at root gastric bypass, you follow a patient for 7 years. Here they maintained a total body weight loss of about 28%. Next slide. And if we follow them a little bit farther up to 12 years, at least in this study, they maintained total body weight loss of 25%. So they're still keeping off, on average, about a quarter of their body weight 12 years after surgery. And if you look at the vast majority, about 70% were able to maintain at least a 20% weight loss. And because people always ask, don't they regain in some cases all their weight? Yes, in this study, 1% did regain all their weight. But by and large, when you look at the overall numbers, patients are keeping about a quarter of their body weight off at 12 years, which is overall fairly impressive. Next slide. If you look overall at SATI and switch, as I mentioned, the results are even better. If you follow a patient for 5 years after a SATI, we're seeing about 38% weight loss. And if you follow them up to 10 years, that weight loss declines a bit to about 34%, but still very impressive numbers overall. Next slide. So that's fantastic. The weight loss is good, but the reason we do this is to improve health. So what does this actually mean overall? Well, if we look early on at 1 year, Matt Hutter did a great study, about 20,000 patients in total in this study. And they found at 1 year, about 15 points were shaved off the BMI after bypass and about 12 points off the sleep. But most importantly, what happened to the comorbid disease? Next slide. 2 slides ahead, please. And what you'll find is with bypass, they had resolution or improvement of their diabetes, about 83% at 1 year, and about the same numbers with high blood pressure. And about 2/3 of patients had a resolution of their high cholesterol and sleep apnea at 1 year. So these numbers are pretty exciting. Some diseases that we typically see a bit of a worsening pattern with time, which actually seem to be potentially reversed or put into remission with an operation. Next slide. Sleeve had some fairly similar numbers. Sorry, just back up one there, Kelly, my mistake. Sleeve had some fairly similar numbers. The one area that I'd highlight that Sleeve seems to fall short is with things like diabetes and high cholesterol. The resolution is still fantastic, but definitely falls short of bypass. We think probably because of that missing malabsorptive component to the sleeve. But overall, good numbers at 1 year. The problem is, as I just said earlier, this is a chronic disease and has to be managed as such. So 1 year data is great, but what does it actually mean long term? Next slide. So an exciting study in our field was a STAMPEDE trial. Phil Shower's group at Cleveland Clinic came up with a study for poorly controlled diabetics. And they randomized about 150 patients to surgery or intensive medical therapy. And the surgery group either had a bypass or a sleeve. Intensive medical therapy group was followed very closely with all the usual interventions you would expect. And the primary endpoint was a hemoglobin A1C of less than 6. I won't bore you with the 1 year data, but it was fantastic. If you had surgery, significantly better chance of achieving the A1C. They did this with fewer diabetic medications, less patients on insulin, and fewer medications overall. So it kind of replicates what we saw in the Hutter study. They actually came back into a 3-year study, which looked very similar. And if you go ahead one more slide there, Kelly, the 5-year data is also similar. So essentially at 5 years now, we've looked at the patients who had surgery had significantly improved chance of maintaining that target A1C. They did this with more of the surgical patients requiring no diabetic meds at all. And surgery resulted in a significantly higher reduction in A1C levels. And as expected, the overall weight loss was significantly better with surgery. Numbers here, 5 years out, patients lost about 19 to 22% of their overall weight. So the data was great. Now what happens at 10 years? Well, we were anxiously awaiting this study. The PI from this, Dr. Shower, she spoke to Fireside Chat ASMBS recently, and all he could tell us was it was very exciting. It should be coming shortly. It sounds like the 10-year data will somewhat mirror the 5-year data, but it's yet to be seen. But it sounds we're anxiously awaiting a release of this. So without that, do we have any other studies that look at it? Well, at 12 years, next slide, we do have at least one study that looks at bypass in diabetic patients. And the outcomes look pretty good. So next slide, we see remission of diabetes about 75% at 2 years, about 62% at 6 years. And with all the patients for 12 years, we see about a 51% diabetes resolution. So it does appear that we have some good long-term effects. And as I was making this talk, next slide, I came across an old cartoon that most of us used to put in our surgical talks. And since Dr. Khan was here, I had to put it in for him today. I was actually going to put it into my talk for his bariatric internal medicine fellows in a couple of weeks, but he knows I don't actually feel this way, so we can skip ahead. So what does this mean about survival? Well, essentially, when we look at cardiovascular disease, don't have a lot of great studies, but it looks like the cardiovascular risks are reduced by maybe as much as 50% at a year. This does taper off with time, but if you look 10 years out, we're seeing some decreased risk of cardiovascular disease after bariatric surgery, and those numbers appear to be most pronounced after routine gastric bypass. Next slide. And looking further at survival, we talked about cancer earlier. We have a couple fairly large retrospective studies of over 20,000 patients, and in the first one, This is a different Dr. Schauer from the US. They found in a retrospective study that if patients had bariatric surgery, associated with about a 33% reduced risk of all cancers. And they looked specifically at those cancers that we know are associated with obesity. That risk reduction was probably almost as high as 40 to 50% in some cases. Next slide. And a similar size study was also done retrospectively with about 10 years of follow-up, and they found that when patients had bariatric surgery, it was associated with about a 25% reduction in their overall cancer incidence, and overall about a 43% reduction in their all-cancer mortality. Skip ahead 2 slides here, please. So we always talk about the Swedish trials. This looked at survival after surgery. A couple thousand patients had surgery compared to a couple thousand patients that did not. Next slide. And it was very exciting. We saw, if we followed patients for about 16 years, that the risk of, when they had surgery, they had about 24% reduction in mortality at 16 years. So exciting data. Interestingly, the Swedish trials used a lot of what we consider very outdated surgeries, vertical banded gastroplasty, lap bands, things like that. And so a lot of us would feel that if we repeated this today using bypass and do it on switch, those numbers actually might be more impressive, but I don't have anything to back that up yet. The only data we could find, next slide, was a meta-analysis. Looking at about 175,000 patients. About 66,000 of those were those that had undergone surgery. Median follow-up is about 70 months. And essentially what they noticed was surgery associated with a mortality rate of about 50%. And they used a modeling strategy to look at life expectancy. It was estimated from their modeling strategy that if patients had surgery, they were probably increasing life expectancy by about 6 years. If they were diabetic and they had surgery, they're probably increasing life expectancy by as much as 9 years. Next slide. And sorry, skip ahead one more. So I did ask Dr. Khan, because the big question for everybody nowadays is, that's great, but how does surgery compare to pharmacotherapy? And the short answer is nobody knows. Dr. Khan was nice enough to share this study with me. He did say, with the caveat, that the data probably isn't very high quality, and I agree with him. We do have a very recent study comparing surgery and pharmacotherapy. The meta-analysis, they only involved about 6 randomized control trials. There's only about 400 patients. Their follow-up was anywhere from 5 to 10 years. You can keep skipping ahead here, Kelly. What they noticed was weight loss was assessed in all 6 studies. The surgical group had significantly more weight loss, about 22 kilograms. They found that they had significantly reduced BMI by at least 8 points. Their cholesterol levels were substantially better. And of course, their A1C levels improved substantially more. I will say this is low quality evidence. I was excited to see this paper was very supportive of surgery, but looking at things, most of the medications included were sort of the, I'd say, older medications, certainly not some of the newer ones on the market. So I don't know that this really proves anything in favor of surgery, although I was excited to read it. I think at this stage, all we can say is there are good pharmacotherapy options, there's good surgical options, and as Dr. Khan alluded to, we probably need both. So I think the take home from this is surgery probably is not as morbid as most people still assume it is. It seems to be as safe or safer than other routine elective cases. We see significant improvement in many diseases as far as 12 years out, and reduction in cardiovascular events and cancer, and overall improved long-term survival. So I think with that, we're still almost on time. We have a little bit extra time afterwards as well. So Dr. Khan, I'll turn things back over to you. If you can go through your algorithm with your case, we'd certainly appreciate your input here.
Thanks very much, Dr. Cassie. And we'll just end with this case as to how do we put all of this together. So, this is a 47-year-old gentleman with long-standing history of obesity. He's newly been diagnosed with type 2 diabetes. That's the reason why he sought care with myself. Has had hypertension, dyslipidemia, obstructive sleep apnea, some of the other complications, among others, of obesity as well. So next slide, please, Kelly. So, how do we make a decision regarding treatment in these cases? So first of all is access. Access is huge, whether they have access to our pillars of management, non-pharmacologic, pharmacologic, bariatric surgery. So, he is basically living close to a center of excellence. So, and he does have private health insurance, that covers these interventions. But then, you think about the goals of treatment. What are the patient's own goals? So he wants to lose between 50 to 60 pounds. So that equates to about 14 to 18% weight loss. And he's also been, diagnosed with diabetes. So he wants remission of diabetes as well. And that's, one of his main goals for treatment as well. Next slide, please. So, in terms of improvement of comorbidity, so he's already developed type 2 diabetes. So, in terms of type 2 diabetes remission, I mean, we would like to see 15 to 20% weight loss. So, that's why the data that Dr. Cassie had shown about bariatric surgery, that is why it is our most important intervention in type 2 diabetes remission. Or the cartoon he showed was spot on. So it is an exciting time to be treating diabetes and obesity. We've got very effective interventions, but we cannot put diabetes into remission, because by definition diabetes remission implies that they are off of all medications, and for that reason, surgery is still our mode of treatment. For diabetes prevention, though, let's say if this patient had only had pre-diabetes, and for diabetes prevention, 5 to 10% weight loss, which at times can be achieved through even non-pharmacologic approaches. So that can certainly be effective in reducing risk of progression to type 2 diabetes. So if he had been in that category, perhaps 5 to 10% weight loss through non-pharm or pharmacotherapy is effective. However, if you're wanting to have remission of type 2 diabetes, still surgery is our best mode of treatment. Next slide, please. So, we've had a holistic discussion. We told him about the percentage weight loss with interventions, as well as with pharmacologic agents, which will likely get him to his goal weight. We are seeing about 15% weight loss. However, as I said, this will be lifelong treatment. They can't stop it, because weight gain does follow, after stopping any of these treatments. Bariatric surgery, the average weight loss is much in excess of 15%. It is likely that he'll have remission of diabetes. However, it is an invasive procedure, but as we know, there is long-term data regarding safety outcomes, regarding mortality outcomes. So, in that case, perhaps the most effective treatment could be bariatric surgery. But while he waits for bariatric surgery, a lot of these other interventions can be done in tandem. So I hope we brought about the point that, treatment needs to be individualized for each patient. And if this was somebody who just had pre-diabetes with more modest weight loss goals, perhaps just non-pharmacologic approaches may be the way to go for him. Thank you very much for your attention. So I think it's, yeah.
Thank you very much. So what I'll do is I'm going to open up the questions in just a second here. I just wanted to highlight our clinic has tried to modify the way things are run here. There's been some frustration in the past from primary care and others with referral process and some pretty tight criteria for who can be referred. And we've recognized that in our region, with obesity rates the way they are, we are missing a lot of patients out there who would certainly benefit from intervention that probably are not accessing it. So essentially, we'll see anybody who's obese that you think may benefit from some input, and we're happy to make those decisions as to sort of what's the optimal treatment for them. Should they go pharmacotherapy, meal replacement, surgery, otherwise? Dr. Khan has been heavily involved in our clinic. We thank him for all the work he's done here. We've also got a nurse practitioner who he's been helping to train, so hopefully the manpower to take all this on. So if you need specifics, Kelly Keeler is our manager who's running things today, or emails at the bottom there if you'd like specifics on referral patterns now, how to best refer these patients. Her email's at the bottom, and feel free to reach out to her. And then maybe before Dr. Khan has to leave, we still have about 5 or 10 minutes. I'll open up to some questions here. Just 1 second. And I'll just open the chat. So if anybody has anything they want to type in the chat, feel free to fire away.
So I believe the only way to ask a question is to go through the chat, as the panelists are, the panelists are the only ones able to talk. So if you do have a question, please enter it in the chat.
I was very concerned we wouldn't leave enough time for questions, but
So we do have one question here. The first question is, did any of the studies look at what kind of weight people were losing?
Yes, I guess you're alluding to whether people lose fat versus lean mass. So if that's the question. Otherwise, the percentages weight loss, like we presented with both bariatric surgery and pharmacotherapy. So there is some loss of lean mass along with fat mass, but proportionately after having had medications, the proportion of lean mass to fat mass is still either maintained or improved, after these interventions. So loss of lean mass, and its sequelae with functional limitations is certainly a risk in some patient population. So that is why maintaining, protein intake, making sure that they are doing sort of strength training as well, can help alleviate some of those goals. It is an exciting time that, there is another medicine that is currently in the works that actually helps patients lose fat mass and helps build lean mass. So at least the first few trials have shown that. So hopefully, the phase 3 trial also suggests something similar. So that would be quite exciting. But for now, there is a loss of lean mass as well as fat mass. But functionally, patients do have improved outcomes, across a whole range of functional outcomes.
Thank you. We have another question here. Did the studies look at disordered eating patterns or guilt and shame with food throughout the study?
So in terms of, so you see, people who've had an eating disorder per se were excluded from most of these large-scale randomized control trials. There have been smaller studies that have looked at, some of those phenotypes, if you will, that, people who have concerns about, excessive craving, people who have feelings of guilt or shame, people who've had, anorexia, people who don't feel full after having regular meals. And for that, they have tried to tailor interventions based on the pre-existing phenotype. So for instance, people that don't feel full after having a regular, 400 or 500 calorie meal, they've tried GLP-1 receptor agonists. Those that crave for food, they've tried naltrexone, bupropion. Those that have, disordered eating or, eating disorder have been referred to eating disorders program. And, matching that phenotype to the intervention has led to better outcomes as far as weight loss is concerned. But those are very small studies, and it is difficult to say if they can be recapitulated, to or generalized to the general population.
Next question, is there any medical screening or testing a patient should do to determine if the weight loss medication can be taken?
So as I said, it is an exciting time in terms of medications, but once again, I let patients know that, this is a long-term proposition. It's not something that they take, for the short run, because we've seen this time after time. Patients do regain most or all of the weight that they've lost after stopping the medication. So that's key message to tell the patients. If they've got diabetes, test them, their A1C. You will see an improvement with weight loss. Other things, to make sure, like some of the contraindications, they shouldn't have a history of pancreatitis, particularly idiopathic or recurrent pancreatitis for GLP-1 receptor agonists. If they've got symptomatic gallstone disease, it's best to defer starting treatment before they have had that treated through a cholecystectomy. History of medullary thyroid carcinoma has been reported in animal studies. Fortunately, it is a rare diagnosis. So, you should screen them or family members for having had that, because then there's a contraindication. Regarding naltrexone, bupropion, once again, the most common side effects is nausea and vomiting. It can increase anxiety. So in patients who've had a history of suicidal ideation or attempts, there's a contraindication. History of seizures is a contraindication as well. So clinically, getting that information would be vital. And none of these medications have been tested in those planning pregnancy, so that's a contraindication as well.
Next question. What are your thoughts on lower dose of semaglutide for weight loss? In brackets, managing results with A/E, as well as maintenance therapy?
Yeah, so we have had experience with lower doses of semaglutide. So as I mentioned, 2.4 is the usual dose. Even at the 1 milligram dose in those with diabetes, it can lead to about 6% on average weight loss. So it can be effective. With sema, particularly if you're using the diabetes formulation, it's important. It's easy that you can titrate up by a couple of clicks each week. So that is something that we certainly have used. Even at the 0.5 milligram dose, I have seen, some weight loss in the order of 3-4%. So that could be clinically meaningful. But it is sort of a dose dependent. In terms of weight loss, it is a clear dose dependent effect. In terms of management of diabetes, it's less so. The average improvement in A1C beyond the 1 milligram dose is just in the order of 0.1 to 0.2 percentage points. So it's not as effective in improving A1C, but certainly is effective in patients to lose weight.
That takes us to the end of our questions.
Thanks, Kelly. I can't see the chat for some reason, so I appreciate you moderating that. So I want to thank everybody for attending today, because it was very well attended, and special thanks to Kelly for moderating everything for us. As I said before, thank you, Dr. Khan, for all of his expertise. We always appreciate your talks that you give here for us and all the work you've done here at the clinic. So thank you very much. And feel free to refer anybody to our clinic. We are looking to see everybody that we can possibly help. And it's a bit more of a team effect there now we can offer pharmacotherapy as well as other treatments with Dr. Khan's help. I think we're sort of offering all aspects of care. So if you have patients you think would benefit, please feel free to reach out to Kelly.
Thank you.
Thank you very much, everybody.